So as I mentioned, the connectionist approach to classifying aphasia is what most neurologists are familiar with, and is kind of the traditional way that we do it. And so, for example, when we're looking in the treatment literature on aphasia, we'll see these terms being used: treatments for patients with Broca's aphasia, or at least in the description of patients, perhaps their classification might be given. And in general, I think this connectionist system is attractive to neurologists because they're focused on anatomy. And one of the things that underlies this connectionist classification system is that there is a direct relationship between where the lesion is and the kinds of the type of aphasia a person has, right? So it's damage to either a part of the brain that's doing something, and or damage to the pathways connecting that region, let's say Wernicke's area to Broca's area. Damage to the arcuate fasciculus, that pathway that connects them, has traditionally been described as the cause of conduction aphasia, wherein one of the hallmarks is that people have disproportionately poor repetition compared to their other language abilities. The idea here being that the word, when I ask someone to repeat, they hear the word, it gets recognized by Wernicke's area, but it's because it's not being able to be forwarded to Broca's area for speech, because that connection between the two has been damaged. You've seen a chart like this in CD558, and we talked about the connectionist system in CD558. Tests like the Western Aphasia Battery and the Boston Diagnostic Aphasia Exam, also known as the BDAE, are really come from this connectionist model. And in the Western Aphasia Battery, and in general, there are four language behaviors that we pay attention to classify people. First of all, of course, there's naming. If a person doesn't have a naming problem, they don't have aphasia. Beyond that, we classify people into, okay, is their speech non-fluent or fluent? After we answer that question, we say, okay, is their auditory comprehension relatively good or relatively poor? So a person who is non-fluent, we know they're non-fluent, and then we say, well, they've also got really poor auditory comprehension. They are classified right there as having a global aphasia. If we say, well, no, their auditory comprehension is relatively good, then we go to the next step and say, okay, what about their repetition? If they have poor repetition, then that's classified as Broca's aphasia. If they've got relatively good repetition compared to their poor speech and fluency, then that's transcortical motor aphasia. Now, these are simplifications, but that's okay for us right now. And I'm not going to say a great deal about the individual aphasia syndromes. Personally, I don't find thinking about my patients as Broca's or Wernicke's is terribly useful. It's useful to the extent to which I might look into the treatment literature for patients who roughly look like my patient. But there's been a lot of criticism of this connectionist system because under scrutiny sometimes it falls apart. In other words, for example, we might have two patients who are diagnosed as having Broca's aphasia with the Western Aphasia Battery, but when we look closely at the underlying processes, semantics, phonology, phonemic buffer, etc., we find that those two people with Broca's aphasia have different underlying processes that are impaired. And so I think that in general, we want to target our treatment as specifically as possible to our patients. And so going beyond this connectionist system and perhaps considering more of a psycholinguistic approach where we're looking at more underlying processes rather than, quite honestly, just symptoms. Because what you see here in the descriptions of people with the different types of aphasia under the connectionist system, they're just description of symptoms. I'll say a few things about these aphasia types in general. First of all, with global aphasia, these are our patients who have the poorest prognosis for treatment. Now, we have to be careful. Right after a stroke, in the early days after a stroke, many people with aphasia appear to be globally aphasic, but then as the swelling goes down in their brain, etc., they quickly evolve into another type of aphasia. Broca's aphasia, because of the tendency for those to be frontal lobe lesions, individuals with Broca's aphasia oftentimes also have apraxia of speech along with it, because of course motor planning and the motor planning regions that when damaged cause apraxia of speech are in the frontal lobe also, and actually right around, or if not in, Broca's area. People with Broca's aphasia have pretty good auditory comprehension. However, if we test them in depth, we'll see that they tend to break down when syntax gets complex, right? So, for example, a person with Broca's aphasia might do just fine understanding the sentence, the boy hit the girl. But then when we take that basic subject-verb-object and we move the subject to the end and we say the girl was hit by the boy, the person with aphasia might interpret that as that the girl hit the boy, right? Because they're just going on order. They're not processing that syntactic move. Whether people with Broca's aphasia have these difficulties processing, understanding complex syntax, whether that's due to some specific syntax mechanism that is impaired, or whether it's kind of a working memory problem, right? A working memory problem because, again, we in sentences that are syntactically complex, oftentimes the sentence doesn't resolve. We don't really know who did what to who until we get to the end of the sentence. And so, of course, we have to hold that information in working memory until it's resolved. Patients with Wernicke's aphasia can be difficult to treat. They often seem unaware of their speech errors, or at least if we judge people by the fact that they don't self-correct themselves as being a sign of poor awareness, then that's more common in Wernicke's aphasia. The Broca's aphasia, for example, these patients are constantly stopping to correct themselves, etc. And perhaps that is partially responsible for their halting, non-fluent speech. Is there a relationship between Wernicke's aphasia, which is characterized by poor auditory comprehension? Is there a link between having poor auditory comprehension and not noticing your own speech errors, and so therefore not attempting to correct them? People have floated that idea out there as one possible explanation. In general, the transcortical aphasias are rare. We don't see them that often just because they represent damages to areas of the brain that are on the periphery of the language areas. They're areas that in general are fairly well vascularized, So they get blood flow from both the middle cerebral artery and, let's say, the anterior cerebral artery in the case of the frontal lobe. Conduction aphasia, also relatively rare aphasia. Anomic aphasia, quite common. And what's interesting about anomic aphasia is that, yes, it's kind of by its very nature, it's mild. But, and here's something that I think is important for us to appreciate, and that is that the severity of their aphasia is not just determined by the scores they get on the tests that we give them. It's also determined by how disrupting that language problem is to that person's life and their self-perception. And so you can have a person with a mild anomic aphasia who's a shut-in and who's avoiding social situations, even though they could do pretty well. Conversely, I've had patients with global aphasia who they didn't let it stop them at all. And I had a patient I can think of right now, could only say a couple words, but after his stroke and he developed aphasia, he found a wife, he got married, they bought an RV, they traveled around the country. He was a social person, and he did the best he can. So even though aphasia might be mild and anomic aphasia, we'll have patients who are quite, they're suffering a great deal by the difficulty they have. And also we have to remember that a person with anomic aphasia might do well on testing, but that doesn't mean that internally there isn't a feeling of slowness, a feeling that it takes longer, a feeling that they have to pay a lot more attention than they normally did. So in general, we should be sensitive to the fact that the severity on our test does not necessarily reflect the impact that that aphasia has on a person's life. And of course, what that means also is that our job is maybe bigger than just improving people's speech and language ability, but it's perhaps also helping them regain as much confidence as they can as communicators, of encouraging them to resume as many of the activities that were important to them as they can, that the activities that were important to them before their stroke, to resume as many of those as possible. And in general, our job is to improve their quality of life.